A 25-year-old male presents with a 4-month history of hair loss. This is what he looks like clinically, and this is a dermoscopy picture. Try and describe or write down what you see and pause the video until you are happy with your description. These are well-defined areas of patchy hair loss, with no erythema or scales seen as prominent and important negatives. On dermoscopy, there appears to be exclamation mark hairs seen with the distal end thicker than the proximal portion, such as where the arrow is pointing. In this case, what would be your diagnosis or differential diagnosis? Alopecia areata is the most likely diagnosis in this case. However, reasonable differentials include syphilitic alopecia, which is described as moth-eaten alopecia, tinea capitis, or trichotillomania. Do you know what the associations are with alopecia areata, or what things you may screen the patient for if they have any symptoms? There are actually many associations, many of which are autoimmune, including thyroid or autoimmune thyroid disorder, vitiligo, lupus, and pernicious anemia. Also, atopic dermatitis, diabetes, and celiac disease are associated with alopecia areata. What else would you look for in an examination to confirm the diagnosis and also to exclude other conditions? So I would examine other hair-bearing areas for similar hair loss. Other than the scalp, the eyebrows and eyelashes are important sites. However, all hair-bearing areas can be examined. Exclamation mark hairs on dermoscopy is very indicative for alopecia areata. There are also nail changes in alopecia areata, such as pitting or tracheonychia. Changes that are not expected to be seen in alopecia areata include erythema or inflammation, perifollicular hyperkeratosis, scale, or loss of follicular ostia, which usually means there is cicatricial or scarring hair loss. What investigations would you consider in this case? Doing a full blood count, thyroid function test, and thyroid autoimmune antibodies would be reasonable. A skin biopsy is rarely needed due to the clinical diagnosis. However, it can be done if in doubt and will confirm the diagnosis. The best area to biopsy in this hair loss condition is from the edge of the affected area. Do you know what the clinical features are that suggest a poorer prognosis in this disease? So if there are extensive areas of involvement, or if there is an early age of onset, less than 5 years old, a long duration of hair loss, or if there is associated atopic disease, these are all poorer prognosis. The other one is if there is what's known as a phaeacis pattern, which means that there is hair loss over the occipital area. This also suggests a poorer prognosis, and these patients tend to have worsening hair loss or may go on to get alopecia totalis or alopecia universalis. What management strategies would you consider in this case? Number one, I usually educate that the treatment is often ineffective and the disease has a variable and unpredictable course. There is no point in getting the patient's hopes up when treatments are usually not great. In terms of first-line therapy, if there's only a small area involved, then moderately potent topical corticosteroids such as mometasone furoate 0.1% can be used. Topical minoxidil, 2 to 5% BD, can be trialled, or irritation-type therapies such as topical dithronol, 0.5% octane, can be trialled. My preferred therapy, if the patient can tolerate, is intralesional steroids, 5 to 10 milligrams per ml of triamcinolone, but beware the risk of atrophy. Injecting into the scalp repeatedly can cause fat atrophy and may cause a depression in the skin. There is a form of topical immunotherapy that can be used with diphencyprine. And in worst case scenarios, often wigs are a good strategy, particularly if the alopecia is severe or if the patient goes on to develop alopecia totalis and universalis. Oral steroids and long-term systemic immunosuppression is usually avoided given the chronicity of this disease and the fact it is cosmetic, although it can be psychologically disabling for the patient. The risks often outweigh the benefits with these therapies. You can also refer to the Alopecia Association.